I think you've seen my face enough today. Let's just get started with our PowerPoint so we can get this done. Okay. I got a frog in my throat. It just jumped in there. Alright, this is chapter 42. And basically what I have done is just shorten the chapter down. For all these testicular disorders, epididymitis, we all have gotten through the A&P. We know where the epididymis is. We know where our prostate is. We know all our anatomy that we're supposed to, we're supposed to know. So usually an infection with the epididymis is going to originate in the prostate, possibly the urethra, and it's going to migrate to the vas deferens. So it's most likely to occur with men that's 20 to 39. A lot of the symptoms is just gradual onset of pain and some swelling, and may cause your testicle to be a little bit swollen and hurt, so you're going to have painful urination, maybe some discharge, run some fever. So basically what we're going to do for that is going to put them on bed rest, elevate their little scrotum with a towel sling, or their big scrotum, whatever you want it to be, which will probably be big since it should be swollen. Heat and cold applications help. If they're going to ambulate, they should have some scrotal support. And of course, we are going to give them antibiotics that are specific to that particular organism that caused it to happen to begin with. Orchitis, of course, is inflammation of one or both testes. It can be bacterial or it can be viral, usually caused by gonorrhea, chlamydia, or E. coli. We have one form of orchitis that's caused from the mumps, which can be seen about 7 to 10 days after mumps. But usually the mumps are going to occur unilaterally. Men exposed to the mumps who've never had the mumps really should receive a gamma globulin shot immediately. Symptoms, of course, are the same as those for epididymitis, and same treatment goes for that, and NSAIDs for pain. Testicular torsion is a medical emergency. So when you have a sudden onset of scrotal or testicular pain that you've not seen an actual injury occur, especially in an adolescent, you should check for testicular torsion. We may need to have surgical intervention in order to save that testicle. So usually they have sudden severe pain, they have nausea, they have vomiting. Hopefully we can get in there and untwist the cords. Hopefully we don't have to remove the testicle. If we do have to remove the testicle, that's going to actually cause him to have some fertility issues later on in life. Hydrocele, you usually see these in infants when they're born. It's just a fluid. Sometimes it will reabsorb itself and sometimes it won't. If it doesn't reabsorb itself, usually we'll have to go in there and surgically remove it, or actually aspirate it out. It's usually not painful, but it does have does put a lot of pressure on the testicles. It's maybe a little bit discomfort. Spermatocele, excuse me. They're a painless sperm-containing cyst that's going to be over the upper portion of the testes. They are usually unnoticed. sometimes they may need to be removed if they get large enough. The varicose, not too excitedly concerned about that. This looks like a bag of worm appearance in the scrotum because it's the enlargement of the veins. You actually can have varicose on the vagina as well. Testicular cancer usually occurs to young men. They should be taught how to do a testicular exam monthly. Young men that have had that will have orchiectomies done because of testicular cancer should actually have some sperm stored in a sperm bank so that they can actually have children later on. It really kind of depends on what type of tumor. Stage 1 and 2 are treated by orchiectomy. So sometimes both testes have to go, and sometimes just one. Prognosis is good. About 95% with stage 1 are cured. Stage 2 has a 5-year survival rate of 91%. So the earlier we can get this detected, the better off we are. Orchiectomy does not cause impotence, which is something they worry about. Seminomas can develop if they've had undescended testes, and usually we have radiation therapy for seminomas that develop for that. Now the big thing with guys is the prostate. So we have all kinds of prostate disorders. So we have prostatitis, we have BPH, we have cancer, we have several things going on with these guys with their prostates. And the biggest thing about the prostate is that it gets bigger. It does enlarge with age. So the prostatitis is an inflammation of the gland, and it can be acute or chronic, can be non-bacterial, can be bacterial. It's the most common ailments men usually have with that they're treated for. Acute prostatitis usually comes from an ascending urinary infection. Usually, the clinical presentation is a little bit different for sort of like with women. It's a little bit different here and there. Usually, we're going to see that they're, if it's an acute prostatitis, they're usually pretty sick. And the doctor will usually do a digital rectal exam, and don't do a vigorous one because we can really cause a disruption in that bacteria and cause some sepsis. We also need to get a UA and all that good stuff. There's a chart on page 1293 that will tell you all the manifestations of acute and chronic prostatitis. It's not easy to penetrate to the prostate with antibiotics, to use antibiotics to cure them. So usually the best thing that we can do is try to make sure that the prostate is empty of ejaculate material because that is a reservoir for infection to survive in. So the prostate should be drained regularly instead of being static and having stasis in there and growing bacteria. So they should either have sex regularly or they should have they should masturbate regularly in order to keep their prostate drained and prevent infections from occurring. There are some drugs that they do give. They do tamsulosin and terazosin, your alpha blockers, to relieve their bladder spasms. So you want to be sure and monitor your patients for that. And of course, teaching them about they usually will get some IV antibiotic therapy, but that's usually the best thing to do to prevent it is to drain your prostate out. Then you have BPH, which is a non-malignant, glandular growth of prostatic tissue. It's going to compress the urethra, causes UTI symptoms, and then eventually will block the urine. Nobody knows why it happens, it just does. The nodules are going to form and along the urethra in a response to the change of hormones, and it's expandable, the prostate is, and so it can grow. Clinical manifestations are kind of varied again. Usually they have trouble starting their stream. There's a chart 42.2 on page 1294. You can read all about the prostate hypertrophy, all that you want to. Sometimes we give Cardura for BPH, and so if your patient has hypertension, you want to be sure that you're checking for orthostatic blood pressure and syncope if you're giving Cardura for this. Same thing with Flomax, because what it does is that it dilates your vascular system, and so it may lower your blood pressure to where when they stand up they have some problems. Medical management, hopefully, again, if they need to keep their prostate drained out to keep it from enlarging, there's medications that we give for that are listed on page 1295 that you can read. And of course we can do surgery, and our surgery that we do is a TURP, a transurethral resection of the prostate, is one of the things that we do. We have patient teaching down there for that. You have to be careful and watch for potential of hemorrhage. The output from a TURP should be the same amount in, and then whatever urine is out. If you have 100 in and you have 20 out, you should stop your continuous bladder irrigation system. That's usually set up with a TURP. You monitor for bladder spasms. They can be caused by clotting, by clots blocking the catheter. Irrigate that with 30 to 50 mils of sterile saline. You want to monitor your urinary bag for blood. If it's light pink, it's normal. If it's bright red, it's not normal. You want to encourage fluids to help keep the urinary system flushed. You want to make sure that your patient knows that even though he's had this done, it will not fix all of his problems all at one time. It'll take a little while. He may even have some dribbling for several months afterwards. So it just takes a little while for the system to get back like it should. Cancer of the prostate, you'll have an increased serum acid phosphate level and an increase in your PSA. It's staged. If it's a stage 0, it's watchful, and then so forth and so on for your stages of cancer. So some of the common signs, if it's cancer, are a lot like the signs of prostatitis. So it's very difficult to determine sometimes on what we're dealing with which disease process we have. Then we have some penile disorders. Well, before we have penile disorders, I put in with the suprapubic catheter, hormone therapy, and education. So we do have suprapubic catheter that when they have a radical prostatectomy, they need to know that they will have that suprapubic catheter placed, and he may need some emotional support because they're going to have some urinary incontinence going on. Once that's removed, he's going to have some erectile dysfunction going on. It's a very difficult one, and it changes their lives very drastically, and this is when they have, of course, the prostate cancer. They may even have to do an orchiectomy if it has spread beyond the prostate. So really, it's very complex disease, and we have to be very careful. Urologist is really helpful when you're doing this particular type of process. So then we have our, we have our penile disorders. And your book has some wonderful pictures in it. It really has a great pictures of Peyronie's disease. So we have phimosis and we have paraphimosis, which basically it naturally occurs at birth, and then as the foreskin loosens, it becomes retractable. So basically, phimosis occurs when you can't retract that foreskin over your glans penis, and it can occur basically at any age. But person needs to be taught how to take care of it. Paraphimosis is if you retract the foreskin and it becomes trapped over the glands, causing a tourniquet effect. The Peyronie's disease is that little crooked penis you see there. It actually has plaque on it, and it will actually cause painful, incomplete erections, and you will also, if you're having sex with a Peyronie's penile problem, then it will be painful sex for the male, and it may be painful for the female depending on the actual curvation of the penis. Urethral strictures, those occur usually because of trauma or maybe some type of infection, and we try to fix it by using some mild surgical procedures like dilation. Sometimes they have to do reconstruction, like with the hydrocele. I mean, not hydrocele, but hypospadias. Injuries to the scrotum are very painful. We should make sure that we know what the extent of their injuries are, how we need to repair them. Penile cancer, it's pretty rare in the United States. Usually we do surgery for penile cancer. May just be a circumcision, or it may be an ablation, or it may be a total penectomy if we have large lesions. If it's caught early, cure is probable. If it reaches stages 3 and 4, chances are we're not going to be able to do anything with that. Priapism is a persistent penile erection related to sexual stimulation. It's painful, and it may lead to erectile dysfunction and necrosis. So some of the common causes are some thrombolytic events such as sickle cell disease and thalassemia. This can also occur with leukemia, but it can also be because of Viagra, psychotropic drugs, cocaine. I don't know how marijuana can cause it, but it's listed in here. So it's actually the engorgement of the penis, and it's considered a true urological emergency because of the potential for compromised circulation to the penis. So anytime they have an erection for more than 4 hours, they definitely need to go to the ER and be seen. Then we have sexual function. And erectile dysfunction in males gets a lot of attention because they sell a lot of Viagra and Cialis and other medications. It's a very lucrative business. It's like weight loss. Of course, erectile dysfunction is inability to obtain or sustain an erection long enough for intercourse. And it could be primary or secondary. Again, just like menstrual periods could. And it can also be psychological, and it can also be physical. So you have to look for circulatory problems, maybe medications. Certain drugs cause erectile dysfunction, such as clonidine, your beta blockers, your tricyclics. Alcohol can do it. So several of your medications can actually cause erectile dysfunction. There's several devices that you can get too. You can get the mechanical devices, the pump, you can get injections, and lots of mechanical devices. Most guys prefer to pop a pill in there that enhances the nitric oxide release needed for an erection. The Viagra will cause coronary vasodilation, so we have to be careful with nitrates. We should never take them together. Or any patient that's taken an alpha beta blocker or an alpha blocker for BPH. Male infertility usually relates to their sperm count. They actually produce sperm up until they die, I believe. But some of the things they need to do is to check the motility and the sperm count. And they may need some testosterone. Vasectomy is, andropause. I almost forgot about andropause. I was talking about andropause. I was saying that their androgen is going to decline, and they may need testosterone to try to rebuild their their stamina because they're losing the testosterone. Nursing care of older men with this problem usually will be to take testosterone replacement therapy and the side effects of it, how to use the medication that comes with it. Now we can talk about vasectomies. Vasectomies, of course, is male sterilization where the vas deferens is actually identified and cut, and then they're ligated. It's kind of like doing a tubal, only it's on the vas deferens. It's highly effective. You have to have 2 semen-free ejaculations before you can actually say that you are sperm-free, so you need to make sure you're using other birth control methods with it. And of course, as men get older, he no longer, we just assume he may no longer have sexual needs, but they may have illnesses that diminish their sexual response, but many men are still very sexually active, just like women are. So, that is basically all I have to say about men and their sexual functions.